Chapter 7, Fluid and Electrolyte Balance. Learning objectives. Discuss the movement of water throughout the body and factors that influence total body water balance. Calculate and interpret blood osmolality and fluid requirements. Identify electrolyte requirements and regulation. Interpret normal serum values for sodium, potassium, and chloride. Explain how the body regulates fluid and electrolyte balance. Describe the type of alterations in fluid balance, as well as causes, signs, and symptoms. Evaluate for and identify alterations in fluid balance and treatment for those conditions. Explain how sodium, potassium, calcium, phosphorus, and magnesium imbalances occur, their clinical manifestations, and treatment. Humans have long known the importance of water for survival. The geographic distribution of population groups throughout the world have been shaped by the availability of water. In medical care, restoration of normal fluid status is often first priority in reestablishing homeostasis. The function of water includes transport of nutrients, transports and excretes metabolic waste, supports cell shape and structure, lubricates friction-generating surfaces, sustains normal body temperature. An important group of solvents found in the body fluids as the electrolyte. Maintenance of fluid balance is significantly integrated with maintenance of electrolyte balance. Daily losses of fluid from the body is normal and require replacement. The presence of injury or illness can result in increased fluid losses and increased fluid needs. Detection of fluid and electrolyte imbalances is an essential component of nutrition assessment. Intracellular fluid is the fluid within the tissue cells. Extracellular fluid is the interstitial fluid in the plasma containing about 20% of the weight of the body, sometimes used to mean all fluids outside of the cell, usually excluding transcellular fluid. Fluids can accumulate within the body cavity in spaces between our organs. These are often called the third spaces and include peritoneal, pericardial, and thoracic cavities, as well as the joints and bursa. Fluid may accumulate in the peritoneal cavity with liver disease, causing a condition known as ascites. Fluid status in the body is in a dynamic state of equilibrium. Water constantly moving, but total volume and concentration remain the same. Fluid moves freely between fluid compartments by the processes of osmosis and filtration. In an osmosis, only water moves between compartments, but with filtration, water and solvents, except plasma, protein, and red blood cells, move. Two types of pressure influences the movement of water and solvents: osmotic pressure and hydrostatic pressure. The force that pulls water across the membrane is osmotic pressure, which is determined by the number of solvent particles within solution. Solvent that does not disperse in fluids, such as the large protein molecules, are colloids, and they also contribute to the osmotic pressure. Hydrostatic pressure is pressure exerted by the fluid on the membrane. For intravascular fluid, hydrostatic fluid pressure, the pressure of blood on the arterial walls, is more commonly known as blood pressure. Osmotic and hydrostatic pressure work together in favor of moving fluid out of the blood into interstitial areas at the arterial end of the capillary and restoring fluid back into blood at the venous end of the capillary. Fluid movement between extracellular fluid and intracellular is directed by osmotic pressure in order to establish osmotic equilibrium. Osmotic pressure can be expressed as either osmolality or osmotality. Though technically they have different meanings, they are similar enough that the terms are used interchangeably. Osmolality is the more precise term since the amount of solvents does not vary. Normal osmolality of the blood ranges from 275 to 295 milliosmoles per kilogram of water, which is considered normal. Most osmolality can be generated or estimated using the serum concentration of sodium, potassium, glucose, and urea. Solutions with an osmolality greater than that of the blood are described as hypertonic, and those with osmolality less than blood are also termed as hypotonic. When cells are exposed to hypertonic solution, fluid moves out of the cell in an attempt to establish osmotic equilibrium. This results is cellular dehydration. When a cell is exposed to hypotonic solutions, fluid moves into the cell, resulting in cell swelling. The physiological role of water in excretion of metabolic waste and maintenance of body temperature results in a continual loss from the body. Losses must be replaced in order to maintain equilibrium of fluid in the body. In the clinical setting, this balance is referred to as intake and output, or input and output. Please review box 7.2 on page 141. Water enters the body as part of food and beverages consumed by individuals. Beverages between 84 to 100% water, such as fruit juices, being at the lower end of the range and water being at 100%. Solid foods range from 0 to 96%, while oils being at 0%. For a food such as a cucumber at 96%. In a clinical setting, anything fluid at room temperature will be considered part of fluid intake. For example, ice cream. Metabolic reactions often produce water, but do not contribute to actual fluid intake in a practical sense. Precise determination of metabolic water is not possible. It is thus usually estimated by using intakes of carbohydrates, proteins, and fat as variables. The role of metabolic water is usually insignificant in cases of decreased organ function. Water has a specific gravity of 1 that will rise with each addition of solvent. It is assumed the healthy adult will have fluid output equivalent to fluid intake, thus maintaining equilibrium. Calculating fluid requirements. Method 1 is based on energy intake. Method 2 is based on age and weight. Please review the calculations. Method 3 based on nitrogen and energy intake. Method 4 based on body surface area. Please review box 7.4 on page 143 for sample calculations. Solutes in body fluids include both electrolytes or ions and other molecules. Electrolytes dissociate in fluid to form one or more charged particles. Other molecules such as glucose, protein, urea, lactate, and other organic acids remain stable in solution. The major electrolytes in the body are sodium, potassium, calcium, magnesium, chloride, bicarbonate, phosphate, and sulfate. Ions with positive charge are referred to as cations, and negatively charged ions are anions. Because some electrolytes are found primarily in either the extracellular fluid or the intracellular fluid, the concentrations of electrolytes inside and outside of cells differ. The key to maintain normal conditions, however, is ensuring that the amounts of cations and anions in the extracellular fluid are equal. In the extracellular fluid, the major cation is sodium and major anion are chloride and bicarbonate. These are found in only small amounts in the intracellular fluid. The major cation in the intracellular fluid is potassium and the major anion is phosphate. Potassium and phosphate concentrations are low in the extracellular fluid. While fluids generally move freely through the semipermeable membranes of the body, cellular membranes can obstruct movement of solvents. Factors influencing movement of solvents include molecular size, hydrostatic pressure, and the method of solvent transport. Electrolyte requirements are generally met by normal dietary intake without difficulty. For example, the adequate intake for sodium is 1,500 milligrams per day, and only 1 teaspoon of table salt contains 2,300 milligrams of sodium. When electrolyte imbalances occur, serum levels are often altered to maintain. The kidneys accomplish primary regulation of sodium, potassium, and chloride. Please review Table 7.3, adequate intake for sodium, chloride, and potassium. Regulation of fluid and electrolytes is complex and utilizes several integrated mechanisms. Thirst mechanism. Cellular sensors within the interstitial fluid are affected by changes in the fluid around them. They trigger the hypothalamus to interpret these signals as thirst. As a result, the individual will be stimulated to increase his or her fluid intake. Please remember, in older adults, thirst sensation decreases. In the trained elite athlete, thirst sensation may not be a valid indication of need for additional fluid. Renal function. When blood volume increases, hydrostatic pressure also increases. This increase in pressure results in larger amounts of fluid moving from the capillaries into the renal tubules. This fluid is then excreted as urine by the kidney. Decreasing hydrostatic pressure Decreasing hydrostatic pressure is the impetus for the renin-angiotensin-aldosterone system regulation of fluids and electrolytes. Baroreceptors within blood vessels are stimulated by low hydrostatic pressure, which is indicative of a decrease in blood volume. The hormone renin is released from the kidney and stimulates conversion of angiotensin to angiotensin 1. A second activation converts angiotensin 1 to angiotensin 2. Two major factors stimulate the pituitary to release the hormone androgen vasopressin. The first and the most important factor is an increasing of osmolality of the extracellular fluid. Vasopressin stimulates the resorption of fluid in the tubules of the kidney, which increases blood volume and lowers osmolality. Please review Table 7.4. Please review Figure 7.2. Please review Figure 7.3. Electrolyte regulation. Sodium. Controls of electrolytes are interdependent and linked to controls of fluid balance, as sodium and water balance are closely related. When vasopressin and aldosterone act to regulate osmolality and blood volume, sodium is regulated as well. Potassium. Aldosterone has an independent effect on potassium levels. High levels of potassium cause the adrenal glands to release aldosterone. Aldosterone secretion results in increased excretion of potassium by the kidneys. Calcium and phosphorus. Serum concentration of calcium and phosphorus are dependent on interstitial absorption, exchange between extracellular fluid in bones, and renal excretion of these minerals. Parathyroid hormone is secreted from the parathyroid gland when serum calcium levels are low. Parathyroid hormone works to raise serum calcium levels by pulling calcium from the bone and decreasing excretion of calcium in urine. Parathyroid also acts to increase phosphorus excretion when necessary. Disorders of fluid balance. There are three general categories of alteration in fluid balance. 1, changes in fluid volume. 2, changes in fluid concentration or osmolality. 3, changes in fluid composition. It is uncommon for these alterations to occur in isolation. Changes in fluid, electrolyte, and acid balance more commonly occur together. Hypovolemia. Extracellular fluid deficit or hypovolemia is also always related to renal or urine excretion or external loss of volume. This will occur more rapidly when the loss is coupled with decreased oral intake of fluids. External losses include any excess loss of fluid outside of the urine excretion, including gastrointestinal losses such as vomiting or diarrhea. Losses through skin occur during exposure to heat, such as increasing body temperature or fever, or increased environmental heat. Other losses occur when fluids are trapped in body spaces, such as the development of ascites in the peritoneal cavity and heart failure, and pulmonary edema in the lungs or in burns. This third spacing of fluid results in a net loss of extracellular fluid. Renal losses occur in conditions that increase urinary excretion above what the individual has consumed daily or orally. Excessive renal losses may occur as a component of a disease process. For instance, they may occur secondary to diuresis, as seen in the recovery phase of acute kidney injury. In uncontrolled type 2 diabetes or hypoglycemic hyperosmolar syndrome, this is the body's attempt to correct acid balance imbalances by hyperosmolality by increasing urine excretion. Hyperglycemia will increase urine output as the body reacts to increased serum osmolality. Medications such as diuretics are often prescribed to purposefully decrease extracellular fluid. The severity of the signs and symptoms correspond to the severity of the volume deficit. As the extracellular fluid decreases, the body volume will similarly reduce. The decrease in blood volume will lower blood pressure and decrease cardiac output. No single lab finding will confirm hypovolemia. Movement of blood and urine will correspond to the underlying causes of hypovolemia. Review tables 7.6 and 7.7 on page 148 and page 149. Hemoconcentration occur in hypovolemia unless there is also a loss of BUN. Treatment is prescribed according to the underlying cause for the fluid deficit. In mild cases, increasing intake of both sodium and water will allow gradual correction of hypovolemia. In severe cases, fluid and electrolyte replacements through intravenous fluids will need to be prescribed. Hypervolemia. In normal, healthy individuals, the kidneys will excrete excess water, but extracellular fluid excess can be common occurrence in clinical conditions. The most common cause of hypervolemia is a decrease in urinary output, such as seen in acute kidney injury. Excess intravenous fluids or the failure of the kidney to quickly accommodate a rapid ingestion of fluid may also cause hypervolemia. Excessive secretion of vasopressin can also result in excessive fluid retention. Accumulation of fluid in the interstitial spaces is also called edema. Increased blood volume results in elevated blood pressure. The presence of edema can be noted in the pressure The presence of edema can be noted, such as in the ankles and the feet, or in the ankle of the feet. Respiratory symptoms include difficulty breathing and the presence of rales. Rapid weight changes also correlate with hypervolemia. A weight gain of 1 kilogram is equivalent to the retention of approximately 1 liter of fluid. Sodium, chloride, hemoglobin, BUN, and albumin would be artificially low in the clinical scenario. Treatment of hypervolemia will target the underlying cause. Control of other symptoms generally involve restriction of both fluid and sodium. Alterations in osmolality occur when there is a shift of water without a corresponding shift of electrolytes. The most commonly involved changes in the concentration of sodium in the extracellular fluid or the hypoglycemia associated with uncontrolled diabetes. A change in osmolality within the extracellular fluid directly influences osmolality of the intracellular fluids. Sodium imbalances. Maintaining sodium levels involves a balance between water and sodium. Homeostasis control is maintained by thirst sensation, diffusion across capillary membranes, and the fluid shift across membranes that allow for adjustment in sodium balance. Normal serum levels of sodium are 135 to 145 milliequivalents per liter. Please remember that levels per hospital might change, so always refer back to what the lab levels are, but our normal serum level for sodium would be 135 to 145 milliequivalents per liter. Hyponatremia. 30 to 45% of hospitalized patients may experience hyponatremia, as it is the most common electrolyte balance. Either decreasing amounts of serum sodium concentration, increasing amounts of water in the extracellular, or a combination of both can cause hyponatremia. In most cases of hyponatremia, serum sodium reflects the ratio of water to sodium. An increase in fluid without a corresponding increase in sodium can also result in hyponatremia. This may occur, for instance, in a situation in which intravenous fluids are administered without electrolytes. Signs and symptoms that occur are consistent with changes in osmolality, nausea, vomiting, or generally associated with serum sodium levels less than 125 milligrams per deciliter. When serum sodium levels fall between 110 to 155 milliequivalents per liter, confusion, seizures, and comas can result. Treatment focusing on elevating serum sodium and treating underlying causes. This can be accomplished by restricting water intake to less than urinary output and by increasing water excretion with loop diuretics. Hypernatremia. Hypernatremia can theoretically be caused by either an increase of sodium or a decrease in water. Insufficient water intake can result in hypernatremia. For example, adults older than 65 years have a decreased thirst sensation and may not take in the adequate amounts of fluids. When serum sodium is greater than 145 milliequivalents per liter, the body responds to increase in sodium serum by increasing release of vasopressors and thus stimulating thirst. The goal of treatment is to gradually lower the serum sodium to normal concentration. If possible, the patient would simply increase his or her water intake, which may return the serum sodium level to normal. When levels fall too quickly, cerebral edema can occur, endangering the patient. Extravenous treatment usually involves slow administration of fluids such as dextrose without sodium. Diuretics and dialysis may be required in some severe situations. Potassium imbalances. The body strives to maintain potassium levels within a very narrow range. Potassium is a major intracellular cation and is responsible for regulation of the intracellular fluid volume. Abnormalities in potassium are often life-threatening due to primarily the role of potassium in neurotransmission and muscle contraction. Distribution of potassium in both extracellular fluid and intracellular fluid is influenced by acid-base balance and hormonal secretion. Hypokalemia. Hypokalemia can result from an inadequate dietary intake of potassium, increased loss from the gastrointestinal tract, such as diarrhea or vomiting, or increased renal excretion of potassium, such with the use of diuretics. Vomiting, nasogastric suction, and diarrhea are common gastrointestinal origins of hypokalemia. One of the most common causes of hypokalemia is the use of loop diuretics, which results in renal potassium excretion. Refeeding syndrome may result in hypokalemia as levels of potassium shift from the extracellular fluid to the intracellular fluid to accommodate increased metabolism. Any body system involving muscular action can be affected by hypokalemia, resulting in muscular weakness and diminished deep tendon reflexes. Normal serum potassium is 3.5 to 5.5 milliequivalent per liter, and hypokalemia is diagnosed when serum levels fall below 3.5. Potassium levels in the body can be corrected through dietary sources of potassium or oral supplements or intravenous administration of potassium. The safest route is to replace potassium with oral supplements. Hyperkalemia. The most common cause of hyperkalemia is inadequate excretion of potassium, which is commonly observed in renal failure. Excessive use of potassium-sparing diuretics, such as aldosterone, may also result in an inadequate excretion of potassium. A shift of potassium from the intracellular to the extracellular can result in hyperkalemia. Signs and symptoms are a result of neuromuscular effects of altered potassium levels. Serum potassium levels greater than 5.5 milliequivalents per liter characterize hyperkalemia. Further diagnosis can be made by electrocardiogram changes. As with other electrolyte imbalances, treatment of the underlying cause is crucial in correcting hyperkalemia. For long-term treatment of hyperkalemia caused by renal failure in chronic kidney disease, dialysis, and a potassium-restricted diet are primary interventions. It is also crucial to prevent malnutrition through adequate nutrition support. Please review Figure 7.7, interaction between PTH and vitamin D in controlling plasma phosphorus and calcium. Continuation of alterations in fluid compositions. Chloride and acetate are primarily extracellular anions. They serve to maintain osmotic pressure and acid-base balance. To correct any chloride abnormalities, chloride is provided as sodium chloride and potassium chloride. Acetate salts are converted into bicarbonates in the liver. Calcium imbalances. Most calcium found in the body is located within bones and teeth. The remaining 1% found in the body fluid is highly regulated due to its functions in muscle contraction. Normal serum calcium levels range from 9 to 11 milligrams per deciliter. Serum calcium is either protein or albumin bound or ionized. Ionized calcium is essential for cellular processes. Hypocalcemia. Hypocalcemia most commonly results from a deficiency of parathyroid hormone or from abnormal vitamin D metabolism, such as that seen in patients with renal or liver failure. Activated vitamin D requires normal function of both liver and kidneys, and thus abnormal of organ functions are a common cause of hypocalcemia. Hypocalcemia can result in symptoms within all body systems. Symptoms are a result of altered nerve transmission and electrical activity of the cell. Untreated hypocalcemia is life-threatening. Serum calcium less than 9 milligrams per deciliter or ionized calcium less than 4.5 milligrams per deciliter is consistent with hypocalcemia. Treatment of the underlying cause is crucial for long-term control. Intravenous admission of calcium is only given in extreme cases due to the potential serious side effects. Hypercalcemia. The majority of causes of hypercalcemia stem from either hypoparathyroidism or from a malignancy. Signs and symptoms will vary according to how rapid the onset or the degree of hypocalcemia. Early signs may be vague and include fatigue and weakness. Bone pain, confusion, and may also be present. Serum calcium levels greater than 11 are diagnostic for hypercalcemia. The underlying causes of hypercalcemia is the focal point of treatment. You must treat the underlying condition first. Phosphorus imbalances. Phosphate is a crucial intracellular anion essential for metabolism for all substrates. It is a component of the cellular energy reservoir, ATP, and the integral part of DNA and RNA. The average daily diet contains 1 to 2.0 grams of phosphorus, which is easily absorbed. Phosphorus imbalances will rarely originate solely from nutritional intake. Hypophosphatemia can result from vitamin D deficiency or from decreased activation of vitamin D, which decreases in interstitial absorption. Hypoparathyroidism can also lead to low serum levels of phosphate by increasing its secretion. Consumption of aluminum-containing antacids may also bind phosphate, making it unavailable for absorption. Respiratory insufficiency and central nervous system abnormalities will eventually lead to encephalopathy and coma. Long-term low levels of phosphate leads to mobilizing of calcium and phosphorus in the bones. Treatment should be focused on the underlying cause of the phosphate. Oral phosphate as food or supplement is the primary route to increase phosphorus. Hyperphosphatemia. Acute or chronic renal failure is the most common clinical condition associated with hyperphosphatemia. Decreased urinary excretion of phosphorus is one contributing factor. Phosphate is released when cells break down, resulting in significant shift of phosphate from the intracellular fluid to the extracellular fluid. Drugs and medication that contain phosphorus or high intake of vitamin D may also result in hyperphosphatemia. Most signs and symptoms associated with hypophosphatemia are results of concurrent hypocalcemia. Let me say that again. Most signs and symptoms associated with hyperphosphatemia are results of concurrent hypocalcemia. Hyperphosphatemia is defined as the serum levels greater than 4.7 milligrams per deciliter. For treatment of chronic hyperphosphatemia, dietary restriction of phosphorus is necessary. Foods high in phosphorus include milk, dairy products, and animal protein sources. Medication that will bind phosphate are also used. In renal failure, where high serum levels of phosphorus are common, calcium supplements are used as phosphate binders to control these levels. Magnesium is an abundant mineral in the intracellular fluid and is necessary for cellular energy metabolism. Its function is closely related to both calcium and potassium because it can assist in maintaining calcium and phosphorus homeostasis, and like calcium and phosphorus, it's partly controlled by vitamin D. 50 to 60% of magnesium is in the body is located in the bone, with the rest found primarily in the intracellular fluid. 50% of dietary magnesium is absorbed in the small intestine. Hypomagnesemia, the most common cause of hypomagnesemia is the withdrawal of alcohol from an individual with chronic alcoholism or from excessive gastrointestinal loss of secretion. Some causes include volume overload, diuretics, low level of phosphorus, and high level of ionized calcium. Signs and symptoms of hypomagnesium are difficult to distinguish from those of hypokalemia and hypocalcemia. The clinician will first rule out other electrolyte deficiencies before attempting to replace magnesium. General symptoms include personality changes, depression, anorexia, nausea, vomiting. Serum levels less than 1.5 milliequivalent per liter or less than 1.8 milligrams per deciliter are considered to be low. Imbalances can be treated with diet and oral supplements. The underlying cause of hypomagnesium should be addressed, and other coexisting electrolyte balances should be corrected. Hypermagnesemia, high serum levels of magnesium are uncommon and generally due to declining renal function or excessive supplements. Supplementation of magnesium containing antioxidants or laxatives is the most common pathway for excessive ingestion. Magnesium is actually used to treat preeclampsia, which is a high-risk condition of pregnancy for both the fetus and the mother. Signs and symptoms include nausea, vomiting, facial flushing, and hypotension. Cardiac function is also impaired, and if uncorrected, may lead to cardiac arrest. Serum levels greater than 2.5 milliequivalent or 3.0 milligrams per deciliter are diagnostic for hypomagnesemia. In mild hypomagnesemia, discontinuation of medication containing the magnesium is warranted. Dialysis can also be used to decrease high levels of magnesium. Many clinical conditions involve impairment of fluid and electrolyte balance. Nutrition therapy must be coordinated with medical care in correction of imbalances. 6 important points to address before assessing fluid and electrolyte balance. Does the patient have a disease or injury that could affect fluid and electrolyte balance? Has the patient received a medication or treatment that could affect fluid electrolyte balance? Is there fluid overload or loss? Has nutrition therapy restricted any nutrient that could affect fluid electrolyte balance? Has oral intake of both water and nutrients been adequate? Do the input or output record balance? Fluid and electrolyte assessment is not easy as it may seem. Many disorders produce clinical manifestations that are vague and often overlap with each other. With experience, the clinician will become proficient in assessment of fluid and electrolyte balance.